Hi, my name is Fred Edelman, and I'm a pediatric neurologist at the University of Wisconsin. I've been in practice in Madison since 1980, and I've seen many children with migraine headaches. So my plan today is to give you an overview of childhood migraine, discuss some of the pathophysiology, tell you how we approach differential diagnosis, and talk to you about treatment and how we can make our patients better. So patients with migraine are divided into different categories. One is migraine without aura, and I'll be going into details with that. Then migraine with aura, meaning a defined symptom complex that suggests someone's about to have a migraine. Sometimes we can see cortical symptoms suggestive of migraine, but the patient does not always or may never have a headache. The other thing to think about is that children can present with migraine in odd ways, and I'll be going into some of these syndromes. Then we want to discuss how to quantify migraine. So patients who have less than 8 migraine headaches a month are said to have episodic migraine, which can be severe, but it's not as disabling as chronic migraine, which means 8 or more migraine headaches a month and often more than 15 days of headache a month. So let's discuss each category a little bit. So some of the definition is based on work in adults, and there are problems in applying these definitions to children. So going back to the adult data, migraine headaches should last between 4 and 72 hours and have 2 of the following characteristics. Unilateral location, meaning one side of the head, and a pulsating quality. They should be of moderate or severe intensity, and they should be made worse by walking or routine physical activity. They often have associated nausea, dizziness, vomiting, intolerance to light, photophobia, and intolerance to loud noises, phonophobia. Patients also may be intolerant of certain smells. Often patients with migraine need to stop what they're doing and rest, and often if they can fall asleep, when they wake up they feel better. Sometimes vomiting can help relieve their symptoms. Now, there's some problems in applying these definitions to children. First of all, many children have briefer headaches. They may last only a few hours rather than 4 to 72 hours. Secondly, most of the children that I see do not have hemicranial headaches or one-sided headaches. They have bilateral, often frontal headaches, but the headaches can occur anywhere in the head. If the headache occurs primarily in the back of the head and is worse with coughing or sneezing, we become concerned that they may have another etiology for their headaches rather than migraine. They might have a posterior fossa mass or a Chiari malformation. Children and adults, however, complain of moderate to severe intensity. On a 10 scale of 0 to 10, they usually rate them about a 7. And children, like adults, want to lie down in a dark, quiet room. As you know, most children are very active, so if a child with a migraine will suddenly stop what they're doing, they often look pale, and they want to lie down and rest. They're often nauseous, they may vomit, and they're intolerant of noise and of light. Now, migraine with aura means that the migraine headache is preceded by a stereotypic behavioral symptoms. If there are one or more fully reversible symptoms from cortical or brainstem dysfunction. The most common aura is visual. The aura usually develops gradually over more than 4 minutes, much slower than a seizure, which would develop much quicker. And there may be 2 or more symptoms in succession. The aura itself should last no more than 60 minutes, and the headache should follow the aura within approximately 60 minutes. However, sometimes the headache occurs with the aura, or the headache may occur before the aura. There is a variant of migraine called familial hemiplegic migraine, which is secondary to a channelopathy and is autosomal dominant. These patients develop weakness on one side that may last longer than 60 minutes, but the symptoms should completely resolve. Now, some patients, particularly more older patients, although sometimes children, can have aura without a headache. So, for instance, people may complain of what are called fortification spectrum, which is like looking at an old fort. Scintillating scotoma means flashing lights with sort of a blind spot. Photopsia are flashes of light that sometimes can also be associated with retinal disease. Patients may complain of field cuts. They can't see to one side, or they may have transient visual disturbance in one eye, which is called retinal migraine. There may be a distortion of vision. Now, less common than visual aura are somatosensory phenomenon. So patients may complain of numbness or tingling or weird sensation, usually on one side of the body. Patients also may have various motor disturbances that may occur at the same time as the numbness. They may lose function in an extremity or be clumsy. They usually don't develop complete plesia. Patients also can develop transient language disorders, particularly expressive aphasia, which can be very frightening. It can look very much like a dominant hemisphere TIA. Another aura that's a little bit unusual is called Alice in Wonderland distortion of size and time. And like Alice taking the liquid from the bottle, things look smaller or bigger, or time seems to move slower or faster. Objects may be seen closer or further away. Patients with this Alice in Wonderland distortion may actually have symptoms lasting more than 60 minutes, but is often seen in association with migraine. Another migraine aura can be attacks of dizziness that can last for a good half hour. Now, there are some unusual presentations of childhood migraine that I'd like to go over. So one is called benign paroxysmal vertigo. This is a syndrome that occurs primarily in toddlers. A child will be walking and then suddenly lose balance, look pale, and may fall to the ground. They may complain of dizziness or spinning. The episodes last a relative brief period of time and resolve, but can recur. These episodes of vertigo are not elicited by change in position as they are in adults, but occur just spontaneously. Another rare syndrome is a condition called paroxysmal torticollis. And this is seen primarily in infants about 18 months of age. They are not born with a wry neck or torticollis, but develop it later on in infancy. And these episodes occur with attacks of suddenly tilting their head to one side. The child may appear to be in distress. And again, there's intermittent nature that occurs periodically and can occur several times in a row. Another presentation is called basilar migraine, and this refers to the vertebral basilar vascular system that supplies the brainstem and the cerebellum. So patients will have symptoms that mimic basilar transient ischemic attacks. They may become unsteady and ataxic. They may have double vision. They may develop confusion or vomiting. Another presentation that I'll go into in more detail is called paroxysmal vomiting. So children at about age 5 or 6, they suddenly have attacks of vomiting. These attacks may occur over a prolonged period of time and may require intravenous therapy and IV fluids. Patients with migraine may suddenly have acute states of confusion. Sometimes this can be triggered by even minor head injuries. For instance, I had a child in school who just hit her head against the locker and then became confused for several hours. This was not a concussion, but this was a child with migraine whose confusional state was precipitated by the mild injury. And then we can see ophthalmoplegic migraine that can actually mimic aneurysmal bleeds. Children can develop ptosis or third nerve palsies. So we're going to cyclic vomiting a little bit more. The mean age of this condition is between 5 and 6 years old. Children develop recurrent severe vomiting. They may have 4 episodes of vomiting in an hour. And these attacks may last hours and even days. So children may require multiple visits to the emergency room. What's concerning is that these attacks of vomiting may occur early in the morning and therefore mimic increased intracranial pressure. They may have other associated symptoms such as nausea, abdominal pain. They may complain of headache. They may have motion sickness. They may have intolerance to light. If these children are followed over time, for instance, about a 4-year follow-up, about 40% develop migraine headaches. And if you obtain a family history, about 80% have a first-degree relative with migraine. So we feel that this is an early migraine syndrome. There are other syndromes that mimic migraine that are rarer. So some seizure phenomenon can appear to be migraine. So if you have an episode of vomiting associated with seizures, it's called ictal emesis. And there's one syndrome with an interesting name, Paniotopoulos syndrome. The children develop emesis, usually at night, with eye deviation. They may have loss of consciousness and even convulsions. Children during an attack appear stressed. They have prominent autonomic symptomatology. They look pale. They may have dilated pupils. They drool. And these autonomic symptoms can immediately precede the episode of loss of consciousness. These episodes of vomiting often occur at night, and therefore if you have migraine patients who primarily have nocturnal events, you should consider this syndrome. One of the ways of documenting the syndrome is to obtain an EEG. The EEG shows multifocal epileptic discharges, but the discharges occur primarily in the occipital regions. So what is the differential diagnosis of the different migraine syndromes that I've discussed? So first, migraine without aura. We need to consider different headaches that may not be migraine. For instance, patients may have tension headaches. The way we separate out tension from migraine is that tension headaches tend to be milder. They tend to be often more persistent. They're not usually associated with as much intolerance to light, noise, or movement. And they often rarely come to neurologists. Cluster headaches can be very severe headaches that we rarely see in childhood, but we tend to see in young adult men, but we can see it in adolescents as well. These headaches commonly occur as someone is falling asleep, which is unusual for migraine. Patients describe horrible stabbing pain in their eye. The eye is usually red. There's often drainage from the nose. These attacks occur in clusters. That's why it's called cluster headaches. And they can cluster over days to weeks and then have long asymptomatic periods. We also have to differentiate migraine without aura from other symptomatic headaches from tumor, infection, or bleed. Usually with tumor, there are other associated symptoms such as seizures. Infection is associated with fever. A bleed can be associated with altered awareness and a stiff neck. So with migraine with aura, we also have to consider symptomatic headaches from focal seizures. So if a patient has a focal seizure, as they're recovering from that seizure, they may have a typical migraine headache. If they do have focal seizures, we have to think about what caused that focal seizure. They may have a definable central nervous system lesion and therefore may require imaging. We have to think about tumors or demyelination, vasculitis, or previous injury. If you have aura without headache, we have to consider focal seizures that can occur in the same area as the aura, or a transient ischemic attack. And it's important to remember that even children are at risk for transient ischemic attack and stroke from arteritis or from other causes. So there are certain red flags that come up in the history that suggest someone might not actually have migraine, but might have something else that might be more life-threatening. So if patients frequently wake at night or in the early morning with headaches, that could be a sign of increased intracranial pressure. If they have prominent vomiting with headache, it might be migraine, but it also could be increased pressure. If the headaches over time are progressively severe and debilitating or change in their quality over time, it suggests that something is evolving that would need to be investigated. We become particularly concerned if someone has headaches in association with seizures and neurologic regression. If someone has fever and stiff neck, they could have an infection such as meningitis. And as we discussed earlier, epileptic mimickers are important. And if we think someone might have an epileptic mimicker, we should get an EEG, and the treatment is anticonvulsants. And to discuss another rare syndrome we see in childhood that was thought in the past to be a variant of migraine. This condition is called alternating hemiplegia, and its onset is usually in infancy or early childhood. There are attacks of eye movement abnormalities. There's something called internuclear ophthalmoplegia that looks like multiple sclerosis, where one eye can't deviate immediately and the other eye has nystagmus. They also may have attacks of weakness with stiffness that can occur either on one side of the body or the other, or sometimes both sides. These attacks can occur frequently and can be associated with severe headaches. Over time, children with this condition develop cognitive and behavioral problems. They may develop microcephaly and spasticity. We now know that these patients often have an abnormality affecting a gene, ATP1A3, critical to energy metabolism. And this condition can be mimicked by other diseases affecting mitochondrial function. This condition, while rare, should be identified because it can be treated with a ketogenic diet. So now let's consider the differential diagnosis of some of the unusual presentations that I mentioned earlier. So if someone has benign paroxysmal vertigo, you do have to think that they might have acute cerebellar ataxia, which could be a post-infectious process. They might have seizures. They might be experiencing labyrinthitis. They might have a posterior fossa tumor or intoxication. Sometimes thyroid abnormalities can present this way. Basilar migraine can mimic brainstem encephalitis, a brainstem glioma, and we have to remember that multiple sclerosis can occur in teenagers. And interestingly, patients with migraine may be at greater risk for multiple sclerosis. Patients who have hemiplegic migraine might actually be experiencing stroke or ischemia and need to be evaluated. They might have a mitochondrial abnormality called MELAS syndrome. They might have demyelination from a previous infection and that's called ADEM, or acute disseminated encephalomyelitis. They might have multiple sclerosis or other causes of demyelination, or they could have a tumor. If a child presents with paroxysmal vomiting, of course, we usually first consider a GI problem, such as GI obstruction. But we also have to consider an increase in intracranial pressure, and some children with recurrent vomiting will have failure to thrive and gain weight. It's called a diencephalic syndrome from a tumor. There's another demyelinating syndrome called neuromyelitis optica, which can involve the medulla, and these patients may also present with paroxysmal vomiting. If a patient has intermittent confusion, we have to think of multiple abnormalities, including subclinical seizures, toxins, trauma, infection, metabolic disturbances, or other metabolic diseases. So let's talk a little bit about the epidemiology of migraine. So migraine is one of the more common problems we see in the pediatric neurology clinic, but also one of the more common problems you'll see in practice. A Swedish study in 1955 suggested that the incidence in Sweden was about 5.3% at age 15. A Cleveland study suggested a prevalence of about 8.6% in children between ages 5 and 13. It's interesting to note that before adolescence, the prevalence in boys and girls is about equal, but that after menarche, it's much more common in women. And in adult women, the prevalence rate is about 18%, and in men about 6%. The prevalence peaks around age 40 in the general population. Migraine, particularly chronic migraine, more than 8 migraine headaches a month, can be particularly disabling, and has been listed by the World Health Organization as one of the most disabling chronic disorders that can be seen. The others would be quadriplegia, psychosis, and dementia. And clearly in my practice, migraine is the most common cause for school absences. So I'm going to discuss the pathophysiology. I'll try not to get too detailed, but there's been some interesting changes. In the old days, people used to think that migraine was primarily due to cerebral vasoconstriction or dilation. Now we know that that's not the case. So clearly, however, there's hereditary factors because 65% of patients have a positive family history. But there's also triggers that can include stress, diet. An interesting one is change in weather. Often with a weather front coming through, my patients will get headaches. And a big problem can be sleep. So children with sleep problems or sleep deprivation will have a migraine. So it's the child with migraine who has an overnight with a friend may almost be guaranteed to have a migraine the next day. So the endogenous factors we think are associated with dysfunction of the brainstem and diencephalon nuclei that serve pain. And one of the ways to think about this is that the intrinsic buffering system that's mediated through the trigeminal nerve is dysfunctional. So pain is transmitted primarily from meningeal vessels, both arteries and veins, through the trigeminal ganglion to the brainstem nuclei, which subsequently synapse on thalamic nuclei, which then send information on to the cortex. Most of the receptors that we're most interested in this system are serotonergic receptors called 5-HT1B or 1D receptors. And triptans, which are quite useful, at least in adults and some children, work as serotonin agonists and tend to block some of this information being transported through the serotonergic system. We now know that triptans may have their effect by decreasing a substance called calcitonin gene-related peptide. Calcitonin gene-related peptide, CGRP, is found in unmyelinated delta and C sensory fibers that serve pain. They're found throughout the body, but they seem to be critical in migraine. We now know that if you infuse CGRP in migraine-prone patients, you can elicit a migraine attack. And if you block CGRP with new medications called monoclonal antibodies, you can decrease migraine frequency in adults. So the pathophysiology of aura is that there is a cortical spreading depression. There's a wave of intense depolarization of cortical neurons. This is followed by neuronal inhibition, and when neurons are inhibited, they are no longer functioning well, and that's how you develop stroke-like symptoms that produce the clinical symptoms of aura. So if the aura occurs in an eloquent area, such as a visual association area, you'll get visual symptoms like scotoma and flashes of light or even a field cut. If the aura occurs in a non-eloquent area, then patients may not experience an aura. The aura also is associated physiologically with non-synaptic transfer of information. There's a transfer of calcium from glia to neurons across gap junctions. Once you have cortical depression, it stimulates the trigeminal nerve, and the trigeminal nerve then causes the release of these calcitonin gene-related peptides and allows transmission of information through the brainstem to the thalamus and to the cortex. And at the same time, inflammatory chemicals are released. And therefore, migraine is quite complicated. It has electrical, chemical, and immunologic elements. This is a diagram from a New England Journal article about the pathophysiology of migraine, and it shows the innervation of meningeal vessels and the information being transported through the trigeminal ganglia to secondary neurons within the brainstem at multiple centers, and then to the hypothalamus and thalamus, and then the cortex. So we'll talk about treatments. So one of the more effective treatments, at least in adults, are triptans. Triptans are 5-HT1B, 1D, meaning serotonergic receptor agonists that work to block transmission of pain. And the most likely mechanism is to block electrical transmission of information through the second-order neurons in the brainstem. Triptans also seem to decrease calcitonin gene-related peptide release, and therefore may affect a migraine attack. Now, people have tried to use antibodies to calcitonin gene-related peptides or their receptors to treat an attack of migraine, but the initial drugs that were developed proved not to be effective or safe. They had liver complications. So now the new variants are used for prevention, not for acute treatment. So again, another image of the transmission of information from the dura and the meninges to the trigeminal ganglion, and then through the brainstem, even down to the cervical nerve roots C1 and 2, and that may be why patients with migraine often have neck pain. So what are the problems in treating childhood migraine? First of all the oral triptans have not been officially approved for patients under 18 because it's hard to prove their effectiveness. The only triptan that has definitely been proven to be effective in a placebo-controlled study in adolescents, 12 to 17 years of age, is sumatriptan nasal spray. So what's done is that patients are treated, and then they have a placebo spray, and they're evaluated at 2 hours afterward for either complete relief of pain or significant relief. And the 20 milligram nasal spray at 2 hours produced a significant improvement in 63% versus 53% in placebo, a high placebo response. And there was complete relief in 2 hours in 36% treated with sumatriptan, but 26% with placebo. We have used sumatriptan nasal spray at lower doses in younger children, but it can be tricky to use. Other forms of nasal triptans have been used and may be effective, but have less data to support them, such as nasal zolmitriptan. So basically, the American Academy of Neurology Practice Committee has concluded that there's no data to support or refute the use of any oral triptan preparation in children or adolescents. So in the pediatric neurology clinic, at times we do try using oral triptans. Sometimes we get a good result, particularly if other family members have improved with it. So why don't oral triptans seem to work in children? It's unlikely that children's migraine have different pathophysiology than adults. Children with migraine grow up to be adults with migraine. So one problem is triptans need to be taken early in the migraine attack to work. And children may not come early enough to seek help. Also, children's migraine tend to be shorter than adult migraine. So at 2 hours, there can be a higher placebo effect than we usually see in adults. Therefore, effectiveness at 2 hours, which is the gold standard to prove effectiveness, is difficult to prove in children. It's worth noting, however, that even adults with migraine may not respond to triptans, and overuse of triptans in children or adults may lead to rebound headaches, meaning that the headaches can become more frequent and even more severe from overuse. So what are the current recommendations for children? First, we talk about general measures. We want to get adequate rest, avoid caffeine. We talk about stress management. Some children are doing too many things and need to make some choices in their lifestyles. We call this the SMART approach to daily living. If a child has a migraine, we usually start with anti-inflammatories, since it's been shown that migraine is an inflammatory process. It's been shown by previous studies that ibuprofen is more effective than acetaminophen for childhood migraine. We usually use ibuprofen at 10 milligrams per kilogram at 4 to 6 hour intervals, but sometimes we do alternate it with acetaminophen. Naproxen can be used 250 up to 3 times a day, or I've used even 500 milligrams twice a day in older adolescents. We need to avoid overuse of analgesics, even over-the-counter analgesics. Ideally, we shouldn't be using these medications more than 3 days a week to avoid rebound. Many patients have nausea and vomiting. Zofran can be quite effective. And we can sometimes give an oral cocktail of medications to treat an acute migraine. Ondansetron, ibuprofen, and diphenhydramine, sometimes with caffeine, can help an acute migraine. Some patients are in migraine status, meaning they have very severe headaches with nausea, vomiting, photophobia, and phonophobia that just do not relent, and they don't respond to the usual medications or sleep. That's called a migraine status. There are different treatments. One is dihydroergotamine. So ergotamines are old-fashioned migraine treatments that had been used in the days before triptans. They're potent vasoconstrictors. They tend to have more side effects than triptans, and therefore they're not used orally as much anymore as in the past. But DHE, given intravenously, can help break a migraine status. The dose is 1 milligram for children 10 years or older, or 0.5 milligram for children less than 25 kilos or 9 years and younger. It's given over 3 minutes by IV every 8 hours for up to 3 days. But before giving the DHE, they need to be pre-treated. The pre-treatment could be prochlorperazine or metoclopramide, or sometimes lorazepam, usually given about a half hour before. But good studies have shown that there's a 75% to 80% response if you use these medications. If a child comes to the emergency room with a migraine headache, they may just have a severe headache but not necessarily be in status. Then the question is what to use. It's been shown that intravenous prochlorperazine at a dose of about 0.15 milligrams per kilogram was more effective than ketorolac alone in treating migraine with an 85% response rate. The problem with giving prochlorperazine alone, however, is that it can have severe side effects. So one is called akathisia, which is sort of a ants crawling on your body type side effects that's very disturbing. This could be blunted if you use diphenhydramine. In practice, in the emergency room, we usually use a combination of Toradol to a maximum of 30 milligrams, plus prochlorperazine, plus diphenhydramine. We like to avoid narcotics or Ultram in children and adolescents with migraine. So again, we do consider triptans. Nasal sumatriptan can be effective. You have an occasional adolescent who may respond to an oral triptan. So it's reasonable to consider it, but know that there's not much data to support it. Now we're going to talk about children with more severe migraine headaches, particularly those with chronic migraines, meaning 8 or more migraines a month, or even if they have one a week, but the headache is particularly disabling and they're missing school. So we're particularly concerned about a child's disability and function, and we use a scale called the pediatric MIDAS scale. So this is a questionnaire, and it assesses function over the last 3 months. And we emphasize that there's no right or wrong answers. So the questions are, 1, how many full school days of school were missed in the last 3 months due to headaches? 2, how many partial days of school were missed? And if you attended school, how many days were you functioning at less than half your ability? Then we also ask about function outside of school, meaning chores, homework, play. How many days couldn't you perform at home because of the headaches? how many days could you not participate in activities that you enjoyed, and how many days were you only participating at about 50% of function. This gives you a total MIDAS score. So the range is 0 to 10 means little to no disability. 11 to 30 is mild. 31 to 50 is moderate. And greater than 50 is severe. So when you have a child with a MIDAS scale in the moderate range with significant dysfunction, we start thinking about daily prophylactic treatment. And there's a lot of controversy about which medications to use in children. So one of the medicines that has traditionally been used is propranolol, and it's the most commonly used medication in adults. This medication was found serendipitously to be useful, had been used in patients who had high blood pressure and also had migraine, and patients who were reporting back that their migraine headaches had decreased in frequency. And then it became common to use propranolol, usually at a dose of 120 to 240 milligrams as a first-line prophylactic medication in adults. If we use it in children, we use it approximately a milligram per kilogram in 2 to 3 divided doses. And it's contraindicated in children with asthma. And you need to use it with caution in syncope, depression, and diabetes. There have never really been very good studies, however, to show that propranolol is useful for most children with migraine. I found that it can be useful in children where stress is a significant trigger. Tricyclic antidepressants have been used both in children and adults for migraine and in a condition called chronic daily headaches. These patients have headaches more than 15 days a month. So the classification of adult studies is a level B, probably effective. But the AAN practice parameters have concluded that there's insufficient evidence to make a recommendation concerning children. But we commonly use it. It can be very useful, particularly in children with insomnia or anxiety. We start at 10 milligrams at night and gradually increase to a maximum of 1 milligram per kilogram. We often obtain baseline EKGs because some children might have prolonged QT interval syndromes, and amitriptyline can prolong that QT interval. We discuss sedation, weight gain, and dry mouth. I always state that patients should take care of their teeth because of the dry mouth. They're at higher risk for tooth decay and should brush well and floss. Anticonvulsants can also be used for prevention. And again, the data is primarily in adults. Valproate and topiramate are FDA approved for preventive treatment of adults with migraine with level A data, meaning the highest level of data. But the AAN, again, practice parameter concluded that it's still insufficient evidence to support or refute the use of anticonvulsants in children with severe migraine. But I have used divalproex, particularly in adolescent boys, and particularly those who may have generalized epilepsy, who may need Depakote for their seizures. And I've been very successful using it in that group. I avoid using it in adolescent women. There's a concern about weight gain, hair loss, ovarian cysts, and the biggest concern is a possible teratogenic effect on fetuses. We've also used topiramate. It can be useful at doses between 25 and 200 milligrams, but we usually stop at about 100 milligrams. The side effects include weight loss, tingling in the extremity, and particularly cognitive effects. I tell people that they should think of Topamax as Dopamax because of its cognitive problems, including word-finding difficulty. You also have to be careful when you treat adolescent girls who might become pregnant. Treated mothers may have neonates with cleft palate. So there's been some studies looking at prophylactic childhood migraine options. There was a study in JAMA Pediatrics in 2003 that was a meta-analysis of all the studies that had come out up to that point. And the authors concluded that only trazodone and topiramate were proven in randomized trials to be at least somewhat effective. Propranolol was shown to be effective in 1 but not 2 trials. They did not find good data for valproic acid. And they found that even placebo was effective in reducing headache frequencies. And they found that the data was more useful and the effect was most useful in episodic migraine rather than chronic migraine. In chronic migraine, they suggested considering topiramate and Botox injections. Excuse me. There was another more recent study that came out in 2017 in the New England Journal of Medicine. This was the CHAMPA study by Powers and colleagues. This was a multi-center placebo-controlled trial of topiramate, amitriptyline, and placebo to treat chronic childhood migraine. The goal was to obtain a 50% reduction in the number of days of headaches, and the effect was assessed 24 weeks after treatment was started. The bottom line was that this trial did not document that there was significant difference between topiramate, amitriptyline, or placebo. So they studied a big coterie, 328 patients, ages 8 to 17, who had significant migraine headaches, at least 4 migraine headaches per month. So they were randomized to topiramate, 2 milligrams per kilogram, versus amitriptyline, 1 milligram per kilogram, versus placebo. And they found that the adjusted odds ratio for at least a 50% or more decrease in headache days compared to placebo was less than placebo for amitriptyline, 0.94, somewhat better than placebo, but only slightly, 1.18 for topiramate. And amitriptyline was less effective than topiramate. And this is a chart that shows this pictorially, and you can, if you look at the green bars, you can see that at 24 weeks, 66% of the patients had 50% or more decrease in headache days treated with amitriptyline, 71% with topiramate, but 68% did as well just with placebo. And there was significant side effects in the amitriptyline group. There was fatigue and dry mouth. In the topiramate group, there was decrease in weight and paresthesias and cognitive change. So that wasn't too encouraging. But one thing that it did show was that with time, many children do better anyway. What it doesn't show is that there are isolated patients who actually do well with either amitriptyline or topiramate, but looking at group data, it's hard to prove. People have used supplements. There's a medicine, a supplement called Butterbur, not a medicine. It works as an analgesic and spasmolytic, and it's shown some improvement without significant side effects aside from belching. Magnesium and riboflavin can also be somewhat useful, but the effect is modest. So what we do in the clinic is we discuss lifestyle using the SMART approach. We discuss sleep. They should have 8 to 10 hours of regular sleep. They should go to bed at the same time each night, weekday and weekend. That can be a hard sell. M is meals. Don't skip meals, particularly breakfast. They may need frequent small meals to prevent hypoglycemic triggers. Fasting can precipitate a migraine. And particularly our athletes need to stay hydrated. A is activities. Children who are active tend to have less headaches, and also they reduce disability, because the most important thing is not just headache control, but to reduce the ability. R means rest and relaxation time, and T is to avoid triggers. So we often ask our children to maintain a headache diary to see if they can identify triggers that could be eliminated and avoid attacks. Now, there are some new treatments on the horizon and some new treatments that just came out for adults that may have implications, at least for adolescents. So one of these new blockers of calcitonin gene-related peptides that have now been approved for adults. There may be other treatments coming out too, such as electrical pulse scalp stimulators or transcranial magnetic stimulation, but cranial magnetic stimulation is not very practical. The electrical pulse scalp stimulators probably are not much better than placebo. So the calcitonin gene-related peptides. These are IgG monoclonal antibodies that have to be given by injection. They block CGRP or its receptors, and this summer have just been approved for prevention of migraine in adults with chronic migraine who had failed 2 previous prophylactic regimens, such as topiramate or propranolol or amitriptyline. There are 4 drugs that are now approved for adults. I won't attempt to try to pronounce them. There are problems, however, in children and adolescents. First of all, they're not yet approved for use in patients under 18, and there's some concern that CGRP may have roles in the body other than migraine. So CGRP is primarily found in unmyelinated pain fibers, but it also seems to be involved in weight gain and bone mass increase. It's involved in fetal development. So it has some risk in young children, and it definitely has risk in pregnancy. The other problem is that it requires monthly injections that most children will tolerate. But we should at least think about the potential use in the future, possibly for adolescents. So we have a certain number of adolescents who are truly handicapped by their disease. They may have 8 or more migraines a month. They're missing school. They may be homeschooled. They may have failed 2 previous prophylactic regimens. When we do the PEDS MIDAS score, they score at 30 or more. And adolescents may be able to tolerate injections. Certainly our patients with diabetes and other conditions give themselves injections. And it may be an alternative to Botox injections, which require multiple injections that can be used sometimes for chronic migraine. But we need to have definite precautions. First, probably there's not enough data and there's some concern enough that it should not be used in pre-pubertal children. And it shouldn't be used particularly in underweight or small children, since it could affect bone mass, particularly around growth spurts. And if a child is very small in weight, it could affect weight gain. It's been shown in animal studies to cause significant problems in fetuses. It's been documented that that antibody from the mother can cross the placenta and affect the fetus after 22 weeks. So it should not be used in adolescents who might become pregnant. It also should not be used if the blood-brain barrier could be disrupted. Interestingly, these blockers don't get into the brain. They affect peripheral CGRP and probably affect the CGRP in the brain secondarily by drawing CGRP out from the brain. And the other issue of cost is the cost. These are very expensive medications, and their exact role is not clear. But their cost may be comparable to Botox injections that are given to chronic migraine patients and even to some of our adolescent patients with chronic migraine. So my conclusion then is that childhood migraine is a common condition. Children with severe, particularly chronic migraine, may be disabled by their condition. And though the mechanism for childhood migraine is most likely similar to adults, it presents in unique ways, and the treatment may differ. Right now, there is a lack of good studies supporting the commonly used treatments for migraine. There is certainly a critical need for studies to establish treatment recommendations and new treatments. The calcitonin gene-related peptide blockers are the first new treatment since triptans for migraine, and they may have a role, particularly in adolescents, but I have to emphasize they're not yet approved for adolescent or childhood use. And parents and teachers are begging us for more effective strategy to deal particularly with the consequences of childhood migraine, particularly the disability associated with this condition. So thank you for attending. So any questions that you might have? And I've listed the bibliography here. Okay, well, thank you for attending, and good luck with your treatment of childhood migraine. Thank you. Okay, we got it under the